While training to become doctors, medical students are faced with stressors, such as academic pressure, financial concerns, and a culture of high expectations. Increased risks of mental health issues such as depression and burnout, which is defined by emotional exhaustion, depersonalization, and reduced personal connection. A meta-analysis the prevalence of burnout and depression were higher among medical students than in the general population, and service utilization rates were as low as 6% for students who screened positive for depression. There are many reasons why medical students may not seek help for their mental health, including lack of time, concerns about confidentiality, and fear of professional repercussion. These barriers to utilization may differ by characteristics such as race, gender, and age, but to date, there is a lack of research examining mental health service use in diverse, national-level, population-based data sets. So, to fill this gap, my Keystone utilized data from the 2017 to 2018 Healthy Mind Study. The Healthy Mind Study is an annual web-based survey examining mental health and service utilization among undergraduate and graduate students. The survey was distributed to 60 post-secondary institutions in 2017-2018. At smaller institutions with a student population of less than 4,000, all students are invited to participate, while at larger institutions, a random sample is invited. This ensures that across all participating institutions, those who are invited to fill out the survey are representative of the full student population. For 2017-2018, the response rate was 23%. Non-response weights were used in analysis so that the responses of students who were less likely to respond based on their gender, GPA, race, ethnicity were weighted more. So for example, females are typically more likely to respond to surveys, so their responses were weighted slightly less in analysis. There were 898 respondents who indicated that they were in an MD degree granting program, representing 48 different institutions. These were the respondents that I focused on during my analysis. So this table summarizes the characteristics of the 898 MD students who participated. I looked at age, gender, race, ethnicity, first generation status, and current financial situation of students. About 55% of students were aged 24 to 27. About 60% were cisgender females, 60% were white, about 11% of students were first-generation college students, and around 70% of medical students reported that their current financial situation was always, often, or sometimes stressful. The Healthy Mind Study also screens students for mental health problems like depression and anxiety. 15% of medical students screen positive for any depression, while 17% of medical students screen positive for any anxiety. And about 30% of students reported that they had an existing diagnosis of any mental disorder. So in my paper, I created data tables of trends in knowledge and attitudes, satisfaction with on-campus services, and barriers to help seeking across student characteristics. But the figures here provide a snapshot of knowledge and attitudes across medical students as a whole. Overall, about 2/3 of students have a high knowledge of where to access on-campus services. This meant that they agreed or strongly agreed that if they needed to seek professional help for their mental or emotional health, they would know where to go on campus. About 1/3 of students had a high perceived need, which meant that they agreed or strongly agreed that they had needed help for emotional or mental health problems in the past 12 months. Next, I found that about 14% of students had a high perceived stigma, meaning that they agreed or strongly agreed that most people would think less of a person who has received mental health treatment. And lastly, about 3% of medical students agreed or strongly agreed that they themselves would think that less of someone who has received mental health treatment. Personal stigma can negatively impact professional conduct and treatment of patients. So while this percentage is low, it is concerning that 3% of future physicians do hold some personal stigma. Next, I looked at satisfaction with convenience, privacy, and quality of on-campus services among all students who utilized these services in the past 12 months. As a whole, students were generally satisfied with the privacy and quality of on-campus services, but about 1/3 of students were not satisfied with convenience, which was defined by the location, ease of scheduling, and hours of operation. Among all students, there were many barriers to help seeking that led them to receive no or fewer services than they would have otherwise received. The most commonly cited barrier was time, with about 30% of students citing a lack of time as a reason for receiving fewer or no services, which isn't surprising given the significant academic and clinical responsibilities of medical students. Some other common barriers to utilization were a preference to deal with issues on their own or with support from family or friends, financial reasons, difficulty finding an appointment, or not knowing where to go. Some students specified other reasons for receiving fewer or no services. The responses here reflect the unique challenges that medical students face, including the need to report treatment on some professional licensing applications. Students were also concerned with the stigma associated with the formal diagnosis, concern of being seen by classmates, knowing how to ask for time off. And additionally, because medical students often spend most of the day in class, in the library, or in the hospital on clinical rotations, leaving them very little time during normal business hours to receive treatment. So clearly, more flexible hours of operation are required to ensure that students who need treatment can receive it. With this overall snapshot of all medical students in mind, I want to highlight some strong findings. First, students of color were found to be 1.6 times more likely than white students to cite a preference for dealing with issues on their own or with help from family or friends as a reason for receiving fewer or no services. This highlights a need for schools to equip medical students with the tools necessary to support themselves and their peers so that they can meet their mental health needs in the manner in which they most prefer. I also found that students aged 20 and older were more likely to be not satisfied with the privacy and quality of on-campus services. And they were also more likely to experience high perceived stigma as compared to students who were younger than 28. So this suggests that the experiences of older students with on-campus services and with the mental health climate on campus should be further investigated so that these services can be better tailored to the needs of this group of students. Another theme that I looked at was a treatment gap among those students who screened positive for depression and anxiety. The treatment gap is defined as the number of students who indicated an apparent need for treatment but did not receive it. Only 46% of students who screened positive for depression had received therapy in the past 12 months, and 43% of students who screened positive for anxiety had received therapy in the past 12 months. For both depression and anxiety, students who screened positive but did not receive treatment were more likely to have a low knowledge of campus services, as well as more likely to have a not high perceived need compared to students who screened positive but did receive treatment within the last 12 months. Campaigns to increase awareness of symptoms so that students can identify when they are struggling, as well as efforts to expand access to information about available services on campus may help minimize this treatment gap. So going forward, future analysis of the data can look at how satisfaction with services and barriers to utilization may differ across various races. In my analysis, I only looked at white versus non-white students, but there could be important differences in trends of knowledge and attitudes and service utilization across different races. Future analysis could also look at the treatment gap among students who screen positive in the Healthy Mind study for other conditions, such as eating disorders. Overall, my research signifies a need for medical schools to administer mental health screenings and link students to services as needed, to focus on delivering services that fit the preferences of students, and to expand gatekeeper trainings. These changes may involve expansion of telehealth services so that students can receive treatment at a time and place that is most convenient for them and allows for the most privacy. My hope is that if medical students have improved access to mental health services, their psychosocial functioning will improve, which will then improve their ability to care for their future patients. Because after all, how can medical students be expected to take care of others when they are unable to take care of themselves?